I'm going to be talking to you about low back pain and the most common questions related to low back pain. And I will ask some questions and I will also answer these questions. Low back pain patients have no definite etiology in about 85% of the time, and they recover in about 6 weeks in about 90% of the time. If you have a patient with a disc herniation for 2 weeks, you don't need to do surgery unless the patient have bladder and bowel symptoms. So 2 weeks, I would go conservative, anti-inflammatory medications and physiotherapy and job modification. 2-day history of severe low back pain, and the patient have no bladder or bowel, no constitutional symptoms, means no fever, no cancer, no neurological deficit. What you're gonna do? We are not gonna get an MRI. We're gonna make sure the patient can have conservative treatment and go back to work as guided by the symptoms. No bed rest, maybe job modification, reduce it a little bit, but go back to work. I think that will help the patient. A patient with gait disturbance and hyperreflexia, in addition to the low back pain. So, when you examine the patient with low back pain, you find that the patient uh, had hyperreflexia, and the patient tell you that they stumble when they walk on a steady gait. So, I would get MRI of the cervical spine. That's not just low back pain. It is cervical myelopathy in addition to low back pain. So this one of the uh, pitfalls of going after limited examination and limited objectives. Just widen the scope a little bit so you can pick the other important things that's connected to low back pain. So the location of the disc is important. If the disc is posterolateral, like here, that will get you the lower number in the level of the disc. I will explain it to you. So if you have L4, L5, and the disc is here, and the disc is posterolateral, that will give you L5 nerve root. But if it is foraminal disc herniation, means it's in the foramina. The posterolateral will be here, and the foraminal will be here. That will get you the exiting nerve root. So if you have L4, L5, it will involve the L4 nerve root, will get you L4 nerve root, the upper number. So normally you get the lower number, rarely about 8 to 10%, you get the upper number because it's foraminal. These are the two types, the posterolateral and the foraminal. When you have disc herniation, you have positive stretch test. When you lift the leg up, the patient will feel pain, a lot of pain, and you have to stop. The pain will increase with dorsiflexion of the ankle. So this is an L5 S1 disc herniation. You can see it here. That will get an S1 nerve root if it is posterolateral disc herniation. The positive stretch test or the straight leg raise will occur when you have irritation of L5 or or S1 nerve root. So the best examination for disc herniation, lumbar disc herniation, is the straight leg raise, as you can see here, called the tension sign. But if it is L4, that will be the femoral stretch, not the sciatic nerve stretch, as you can see here. So the patient will get nerve pain when they get this herniation, a sharp shooting pain, like electric shock that radiates to the leg and the foot. It is the sciatica kind of pain. There may be burning, tingling pain, and some numbness. Sciatica is a self-diagnosed condition. The patient can feel it, they can diagnose it themselves, usually improves with time. It doesn't need surgery in every patient and every case. So 8 weeks now, and the patient had lumbar disc herniation, and the pain was there, and he's not telling you what happened to the pain. So when do you do surgery in that patient that have a lumbar disc? You do surgery when you have refractory radicular pain, means when the pain is not getting better with conservative treatment. They say stable motor loss. So stable motor loss can be loss of extension of the big toe, and it's stable, is not progressive. You don't do surgery just because of that. You do surgery when they have the pain intractable, the patient cannot tolerate the pain. So let's diagnose it now. In addition to the sciatica, you go examine the patient. So you have disc herniation at L5S1, posterolateral, so that will get you the lower number, S1. The S1 will affect what? The lateral aspect of the foot. So the way to remember it, L5 nerve root will get you the top of the foot. The S1 will give you the lateral side of the foot, decreased sensation. L4 will get you the medial side of the foot. L5 top of the foot, S1 out, L4 the medial side of the foot. And look at here, look at this. So this is a disc herniation posterolateral at L4, L5 level. That will affect L5 nerve root, top of the foot. What else? The big toe. The big toe, extension of the big toe. That's a very important exam for disc herniation. L5 nerve root, the big toe. How about central disc herniation? Central disc herniation is a problem because it wipes out multiple nerve roots, not just one, multiple. And they call it coda equina. It's dangerous. It's an emergency. You need to get an MRI immediately and diagnose it, and you need to do surgery urgently in the patient. If you don't, you lose the bladder and bowel of the patient permanently. So the patient will walk with diapers. You don't want to do that. This herniation that is dangerous, I would think that is the central one. And that central one is, you see it here, it's in A. And that disc herniation in A is right here. This is foraminal, and this is posterolateral, and this is sequestered, means a piece is separated. So the one that's dangerous is the central, because it affects the bladder and bowel. 25-year-old man with large central disc, he got perianal numbness. This patient will most likely experience what? Bladder and bowel symptoms. Central, perianal numbness. This is coda equina. I will look for the bladder and the bowel symptoms. I will ask the patient. This is one of the things you ask the patient when they come to you with low back pain. Do you have bladder and bowel symptoms? If you have, it's an emergency. You don't treat that patient conservatively. This patient will need surgery if they have that MRI documented, then surgery. Lumbar stenosis. In lumbar stenosis, you can see how the spinal canal, like this, it changed to be triangular in shape. And the exam is normal in about 50% of the time. You'll have the shopping cart sign, means when you go to the mall, they bend over the shopping cart. They can't walk in the mall, but they can walk if they have the shopping cart. Because when they bend the spine, they feel a lot better because they open their foramen. Patients with lumbar stenosis have difficulty in what? In walking in the mall. Riding a bicycle is good for them. They can do it. But if you have vascular claudication, you can't do it. So for spinal stenosis, you can do it. So in a patient that have a spinal stenosis will be able to do what? Ride a stationary bike. But that will need muscle movement, and the vascular claudication does not have enough healthy oxygenated muscles to make that movement. So in spinal stenosis, right, a stationary bike is a piece of cake for them. So you have a patient with buttock pain, leg pain, get tired from walking more than 2 blocks, he can't. They stop. The MRI shows that there's lumbar stenosis. You're going to evaluate the patient. The evaluation should include examination of the peripheral pulses, because you can have vascular claudication in addition to neurogenic claudication, or it can be just vascular claudication and you have the wrong diagnosis. Another story here: buttock pain, walking is hard. Examine the pulses. Examine the pulses. Twice, I get the question in different ways, and people are still making mistakes. They say, get an EMG. EMG is not going to help you. Examine the pulses. Make sure that's part of your treatment. You want to make sure it is not a vascular claudication. You also want to make sure it's not a hip problem or a tumor or something else. Examine the pulses, very important. You want to make sure that it is really low back pain and not sacroiliac joint pain, because both can be confused in the diagnosis. The far posterior pain can come from the sacroiliac joint, and this is a very, very occult condition. A lot of people don't know how to diagnose that. So you have a patient with low back pain. You don't know if it is SI joint pain, hip pain, or a spine. So what do? You may want to examine the patient first, and then if you can't decide, inject the sacroiliac joint. That is the answer. There's another problem, which is it really a spine problem or a hip problem? Because when the patients say, I have hip pain, maybe the hip is the buttock area, and maybe that's coming from the spine. So ask the patient to point where is the pain, and then try to differentiate. Is it a spine or is it hip? One of the things you can do, for the differentiation is to inject the hip. It's an easier technique, but also will delay your surgery in the hip for 3 months. If the patient is out of work for 6 months and he was not given rehab for his low back pain, the chances of the patient going back to work is about 50%. Just 6 months. 1 year, 25%. The patient is out of work for 2 years, the chance of going back to work is 0%. The nucleus bulbosus have type 2 collagen, soft type 2 cartilage. How about the Trendelenburg gait? Trendelenburg gait is the gluteus medius and minimus deficiency can contribute to that, or the superior gluteal nerve can contribute to that, or a disc herniation, ipsilateral, paracentral, which is posterolateral, at L4, L5, because you want the L5 nerve root to be affected in this condition. So how you get the L5 nerve root? It have to be paracentral, the ipsilateral here, far lateral, L4, L5 will get you L4. L5 is Trendelenburg gait. L5. So will come from here. L4, L5, posterolateral or paracentral disc herniation. Which condition causes the winking owl sign? Tumor. You got 2 pedicles like that. So when you destroy one pedicle, you look at the AP of the lumbar spine, and you find that you have a winking eye, like you call it the winking owl sign. So this one will be destroyed, and you have the other one open. This is a winking owl sign in tumor. Thank you very much. I hope that was helpful. I think I tried to get you the most common questions and the most common answers, for these questions. And hopefully that will help you, and I will do more down the road. Thank you very much. I appreciate that. Thank you.